Should I start, ma'am?
Sir, can we start? Yes, you can start now.
We are right now, ma'am, on YouTube.
Good afternoon. I, Dr. DP, have the pleasure and the privilege to welcome all of you to the 9th Professor R. Nath Memorial Oration. Due to the COVID-19 pandemic and requirement for maintaining of social distancing norms, this oration is being conducted on the digital platform for the very first time. I request Professor Savna Sharma, Head of Department of Biochemistry, to officially welcome all the dignitaries and the participants.
Thank you, Dr. DP. A very good evening to all of you. And I thank you, all of you, for being here with us today. I, on behalf of Department of Biochemistry, PGIMER, Chandigarh, take pride in welcoming you to the 9th Professor R. Nath Memorial Oration. I would like to express my sincere gratitude towards our esteemed director, Professor Jagatram, worthy Dean Academic, Professor Jitpuri, and Dean Research, Professor Gurpreet Singh, for their encouragement and support to organize this oration during the COVID pandemic. I extend my warm welcome to Professor Hari K. Khal, who is Professor and Head Department of Biochemistry and Molecular Biology at Louisiana State University, New Orleans, and he is the orator of the day. My special thanks to Professor R. Nath's family for their continuous support to hold this oration. So once again, I welcome you all on this occasion.
Thank you, ma'am. I now request Professor Jagat Ram, our esteemed director, to kindly welcome our orator, Professor Hari K. Khal, and give a brief introduction of Professor R. Nath, on whom this prestigious oration has been instituted.
Good evening. Our today's chief guest and orator, Dr. Hari K. Khal, Professor and Head, Department of Biochemistry and Molecular Biology, and Associate Professor, Director of Stanley S. Scott Cancer Center, School of Medicine at Louisiana State University, Health Sciences, New Orleans, USA. Professor G.D. Puri, Dean Academic, Professor Gurpreet Singh, Dean Research, Professor Avindra Nath, Professor Sadhana Sharma, Head Department of Biochemistry, PGI, other faculty members present here, resident doctors and friends. On behalf of Postgraduate Institute of Medical Education and Research, Chandigarh, I would like to welcome all of you to the 9th Professor R. Nath Memorial Oration of the Institute. This oration is being conducted in the memory of Professor R. Nath, who was former head Department of Biochemistry at this institute. Professor R. Nath was born in 1932 and completed his PhD from Indian Institute of Science, Bangalore, one of the premier institutes of our country. He started his career as a faculty of University of California, San Francisco in 1959 and later joined as a faculty in the Department of Biochemistry at PGIMER, Chandigarh in 1964. He has been head Department of Biochemistry at PGI from 1981 to 1992. During his tenure in the institute, he trained nearly 100 postgraduate students. Professor Nath was a Professor Emeritus from 1993 to 2002. Most of the faculty members, those trained by him, are now occupying the top position or chairs in major universities across India and abroad. He was founding member of the International Society of Trace Metal Research, American College of Nutrition, Urolithiasis Society of India, Indian Academy of Neurosciences. Professor Nath received numerous awards and honors, including Fellow of the Indian Academy of Medical Sciences, Indian Academy of Neurosciences, Society of Toxicology, and American College of Nutrition. He had been visiting professor at the University of Auckland, University of Texas, University of Toronto. He has great contribution in the field of trace element metabolism with special reference to their binding proteins. Most importantly, Professor Nath was instrumental in initiation of All India Integrated Program on assessment of the heavy metal in air, water, food, blood sample, funded by the Department of Environment under DST, New Delhi. He was very enthusiastic about his research and published more than 250 research publications and several review articles in the reputed international journal. Professor Nath had relentless optimism and is remembered as a great scientist by the scientific community. Above all, he was a great teacher and considered the whole department as an extended family. My personal interaction and association was for more than 30 years. Unfortunately, he passed away on 17th of October 2002 after a prolonged illness. After his sad demise, his family had instituted Professor R. Nath Memorial Oration in his fond memory, which is held every alternate year. It is a matter of great pride that this year it is the 9th Professor R. Nath Memorial Oration is being delivered by Professor Hari K. Khal, who is one of the internationally renowned scientists in the field of urological diseases. I thank Dr. Khal for accepting this invitation and welcome him for this oration. I also extend many thanks to the family of Professor Nath and Professor Avindra Nath, who is present with us today, for their continuous support to hold this oration. Thank you very much.
Thank you, sir, for sharing this valuable information with all the participants. I once again invite Professor Sarna Sharma to kindly introduce our orator, Professor Hari K. Khal, and speak a few lines highlighting his illustrious achievements.
It's my profound privilege to introduce Dr. Hari K. Khal, Professor and Interim Chairman of Department of Biochemistry and Molecular Biology and Associate Director at Stanley S. Scott Cancer Center, School of Medicine, Louisiana State University, New Orleans, USA. We are indeed very thankful to him for accepting our invitation to deliver this prestigious Professor R. Nath Memorial Oration of the Institute. Dr. Khal is internationally recognized as one of the leading translational researchers in urological diseases. He got his postgraduate degree in the year 1986 in biochemistry from Kashmir University, Chandigarh, and completed his PhD in year 1990 from PGIMER, Chandigarh, under the mentorship of Professor R. Nath. And it is indeed a matter of great pride now that he is going to deliver Professor R. Nath Memorial Oration. He received postdoctoral training at University of Massachusetts Medical School, USA, and served as a senior staff scientist and founding member of the urology research team at Henry Ford Health Sciences, Detroit. He was appointed as a professor and director of urology research at the University of Colorado. After that, he had worked under various capacities in internationally recognized institutes. Dr. Khal has been appointed as professor and chairman at the Department of Biochemistry and Molecular Biology at Louisiana State University in February 2020. Dr. Khal is recognized for his scientific leadership and contributions to understand molecular mechanism in urological diseases across the globe. He has numerous publications with high impact factor in reputed journals with H index of 32 and more than 4,000 citations. In recognition of his scientific contributions and research leadership, Dr. Khal was elected President of the Society of Basic Urology Research, Fellow of the American Society of Nephrology, and Fellow of American College of Nutrition. He is recipient of the Outstanding Achievement Award of the Society of American Asian Scientists in Cancer Research in year 2009. His current research interests are focused on GU oncology with special emphasis on pathophysiology of prostate cancer. Very recently, he has been awarded with VA Merit Award and NIH-funded research support of around $1 million to find new therapeutics against prostate cancer. Dr. Khal, we look forward for your knowledgeable lecture entitled Tumor Progression and Therapeutic Resistance in Prostate Cancer on this occasion and welcome you to deliver this oration.
Thank you, ma'am. Thank you, ma'am. It is definitely an honor to have Professor Khal as an orator for this 9th Professor R. Nath Memorial Oration. We have with us Dr. Avindra Nath, eldest son of Professor R. Nath, and we extend him a special welcome. Dr. A. Nath is a well-renowned physician scientist who is currently working as the Chief and Clinical Director of National Institute of Neurological Sciences, Neurological Disorders, and Stroke at NIH, USA. He has notable contributions in the fields of HIV, dementia, epilepsy, to name a few. I now request Dr. A. Nath to speak a few words.
You have to unmute.
Unmute.
You're not audible, Dr. Nath.
I usually like talking to myself. So first of all, I wanted to thank the director as well as Professor Sharma and Professor Khal for making this oration happen. And I'm very grateful for the very kind remarks about my father. I grew up in Chandigarh for the most part, and I have very fond memories of the Department of Biochemistry and PGI and Sector 24, where we lived and interacted with all the faculty there. So I have a few pictures that I'd like to share with you. And so let me see if I can share my screen here. Are you able to see it? Oh, okay, good. So this was just a second. I think. This is the one I wanted to share. Okay, so I hope you're able to see this PowerPoint here.
Yes, we are able to see.
Okay, great. Okay, so this is a picture that was taken, I think, around 1992. That was the last year that he was the head of the Department of Biochemistry, and this was his office there. And I think you already mentioned his career, so I'll skip that. And this is a photograph of when he received the fellowship to the National Academy of Medical Sciences. This is what PGI looked like in those days. I don't know what it looks like now, but what I remember really well is you had the Fiat, Standard, and Ambassador. There were only 3 cars in those days, and most everybody came on scooters. Yeah, and so and that was him over here. Okay, and this is again a picture of PGI, and unfortunately I don't recognize most of the people here except for my father, but some of you might. I think he was probably the director at that time. Okay, and this was a sabbatical he took for 2 years at Christian Medical College. And there he was chair of the Department of Biochemistry. But I wanted to point out here Vijay Lyle. He used to be he was his first graduate student. And Kartar Singh and then Vijay Lyle. They were the very first graduate students. And so he did go to Ludhiana and then came back to PGI with them. But the thing is that it was always the Department of of biochemistry was an extended family for us. They were frequently at our house all the time. We had all kinds of parties for all the students and faculty here. So we knew one another really well. Yeah? And because of those interactions, for example, with Vij here, we continue to have very nice relationships with them. And from time to time, we still interact with a number of his previous students. And this is at some poster session here, again, with a number of these students, and you might recognize some of them. I wanted to say a couple things about my mother, because she really took care of all the students and faculty, because when they were at home, she was doing all the cooking for them, and she socialized with them, and then she would go to all the conferences with them as well. And so this is at one of the conferences there. And then after he passed away, she was the one who actually initiated this lectureship over here, and she would attend these lectures every year and take all the delegates out, department out for dinner at the end of the lecture. And unfortunately, we cannot do that this year, so we'll miss it. But I'd like to thank a number of people here for it. Dr. Sharma, the Department of Biochemistry for supporting this. All the previous heads of the biochemistry department have all been very supportive. Each of the directors of PGI have been very supportive of this lectureship. And the LRN Foundation that is formed by my two sisters and myself, and Professor Khal for doing the lectureship. I will stop here. Thank you.
Thank you, Dr. Avindranath, for sharing such nostalgic moments with all of us. Thank you so much for being with us. It is now our great privilege to invite Professor Khal to kindly deliver today's oration on the topic entitled Tumor Progression and Therapeutic Resistance in Prostate Cancer.
Let me, give me a minute here. So is my screen audible? Audible, can you see my screen?
You're visible and audible both, sir.
Thank you. Professor Jagat Ram, Director of the PGI, Professor Sadhna Sharma, Head Department of Biochemistry, Professor Avindranath, Monica Nath, members of Dr. Nath's family, distinguished guests, and colleagues across the globe. It is indeed a privilege to be with all of you this afternoon in India, early morning here in United States. The day brings lots of memories from about 35 years back when I was a graduate student at PGI. I think I'm one of the last graduate students from Dr. Nath who trained under his guidance. Today, my task is much easier to talk about the work I have done in the last decade or so on tumor progression, therapeutic resistance in prostate cancer. Just before the meeting started, we had a little chat with Dr. Nath's son, Avindranath, and he said, "Thank you for waking up early." I said, "That was the routine when you trained with Dr. Nath. We had journal clubs at 7 o'clock. Even if you worked all night, you had to be at 7 o'clock there." But without further ado, let me see if I can move my slides. Yes. So I will talk to you about therapeutic resistance. Then I will also share some of our work on role of prostate-derived X transcription factor, which is PDF and also called SAM-pointed domain X transcription factor in preventing prostate cancer progression. So this is prostate cancer is a secretory gland, and this is the structure of one of the glands, how they look like. They have these basal cells, and then they have these luminal cells which secrete secretions. Unfortunately, as the disease progresses, we get disease where these cells keep on dividing outside the gland. Some of them become metastatic, others change lineages from epithelial cells to more mesenchyme-like cells and then neuroendocrine cells. And these are the only cells that respond to therapy are these luminal cells. So currently we don't have any treatments for these metastatic prostate cancer. So to refresh our memories, this is one of the pictures from our research group. We were quite young those days, in Dr. Nath's office on his couch. I will share some of these pictures during my talk to just lighten you up and bring back the memories of the times we spent at PGI. Coming back to our topic, prostate is a gland which is at the base of the bladder. Normally, it allows urine to flow continuously. Whenever the bladder gets full, the pressure comes in, and so the prostate opens up, helps to open the outing so that the urine can pass. One of the major conditions affecting older men is this benign prostatic hyperplasia. When the prostate gland becomes big, it becomes fibrotic and shrinks. This narrows the tubing from the bladder. And so many people have to wake up many times at night so that they can pass their urine more often. So this disease is benign condition, but the main disease that is lethal is prostate cancer, when these cells in the prostate gland start dividing without control and laser pointer. So these cells start dividing in the prostate, and as long as the disease in the prostate, there are many treatments that can be available to these patients. But once the disease starts spreading beyond the prostate, there's a local spread and then the metastatic dissemination of the prostate cancer. For now, we do not have really good options for these patients. To look at the statistics in the United States, in last year, 248,000 men were diagnosed with prostate cancer, and about 34,000 of these men died of the disease. So 11% mortality rate. So there's a large pool of men who get the disease, but a very small fraction of those men die. So there's a lot of indolent disease and then the lethal disease. And we do not know, unfortunately, which patients will become lethal and which patients will have no consequence, almost no consequence of prostate cancer. So this is an unmet need at this point. Now, globally, in 2018 estimates, about 1.2 million new cases of prostate cancer were diagnosed across the globe. So the burden is real, and mostly it is the men, older men, who suffer from this disease. So for today's talk, my scope will be limited to prostate cancer biology, hormonal therapy for prostate cancer. I will talk about tumor progression, then mechanisms of therapeutic resistance as we know them. Some of them I will skim through, but just to give you a kind of an overview of the process. Then we will see whether or not we can explore these vulnerabilities in tumor progression to attack this problem of therapeutic resistance. I will also share with you some of our published and unpublished work on this ETS transcription factor, which was discovered in prostate gland itself, but is also present in other glands. We will talk about regulation of gene expression by PDF and analysis of PDF-associated genes in clinical data sets in prostate cancer patients. So as I told you, as long as the disease is localized, there are many treatment options for prostate cancer, including surgery to remove the prostate, which can be done either by laparoscopic methods or by robotic methods. There's radiation therapy, there is burning or freezing, there's a radio frequency. So there are many modalities that help overcome the initial disease as long as it is confined to the organ. There's also active surveillance for patients who have a very low-grade early disease because, as I told you before, there's lots of indolent disease present, and these treatments for the therapy of prostate cancer are not benign by design. They have other consequences, including loss of sexual functions and loss of urinary control. So there are many conditions. under which surveillance is offered, or active surveillance is offered, and only when the disease progresses, these patients will receive treatments. But despite that, a study from Johns Hopkins showed that in 2006, 234,000 men were diagnosed with prostate cancer. About 90% of these men, that's 211,000 men, underwent definitive treatments, which included either surgery, radiation, or other modalities. And in 2016, 52,000 of these men became recurrent with the disease, suggesting that even though we believe that the current treatments are effective when the disease is localized, there is about a quarter of patients who do not have benefits or who do not have prolonged benefits of this treatment. One of the ways a pathologist looks at the disease is how the glands look. If the glands are circular and well organized, this is a normal looking prostate. In early grade prostate, these glands start becoming bigger. They fuse with each other, and they're still Gleason 2, 3 grade disease. Still the cells are within the gland, but this Gleason 4, when these glandular cells spread from the gland and then start invading the surrounding tissues, and eventually they move away from the prostate to other organs and cause lethal conditions. So this is how a pathologist look is. Now, if the disease was this simple, we could easily treat it and we could easily see which patients we want to treat. However, a pathological section from the prostate shows the disease is heterogeneous. In the same patient, it is based on the biopsies that we take or the physicians take at the time point. Depending on where you hit, it's a hit or miss at this point. We only sample very small area of the prostate, and if we miss this bad area on our biopsies, you may look, the prostate looks normal, or the prostate may have a very bad disease. So heterogeneity within the tumor and within the same patient, many times even within the same nodules, is a very challenging task in prostate cancer. Now, it asks me to approve something or decline. I have no idea how to do that. Maybe if you can take the requests. I can't see my screen.
Yes, sir.
Can you, there's a screen showing annotation request.
No problem, sir. You go ahead. We will.
It is blocking my screen. Okay, thank you. So for the organ-confined disease, I told you there are many treatment options, but once the disease is extracapsular, androgen deprivation therapy, which is also called chemical castration, is used as a method of controlling prostate cancer. However, there's a therapeutic failure, and then the tumor starts growing back in an androgen-independent manner. At present, we do not have any curative therapies for these patients who fail hormone ablation therapy. So there are second lines of treatment for androgen ablation therapy failures, which is chemotherapy in last stages of disease, immunotherapy. There are synthetic androgen blockers. There are new agents. Most of them have a limited value of 3 to 5 months survival advantage, and we clearly do not have any treatment for castrate-resistant metastatic prostate cancer. To look at the schematic, if you look at early stage, when you get diagnosed with prostate cancer, patients are offered surgery or radiation, then there's a lap, the disease goes down, but the tumor starts coming back, and most of the time they are given androgen deprivation therapy. Tumor starts responding and the tumor volume goes down, but then the tumor starts coming back. At that time point, there are newer generation of anti-androgens, LHRH inhibitors, which slow down the process, but eventually many of these patients fail and the tumor grows again. When chemotherapy is offered during symptomatic conditions to lower the tumor volume, and post-chemotherapy, there is no treatment available, many of these patients end up dying. Now, the timeline is very important in prostate cancer. This whole process is about a decade long. So if you had an indolent disease diagnosed and you had a less life expectancy or an older male, probably none of these treatments would be needed. Androgen deprivation therapy may be sufficient. Unfortunately, if the disease has metastasized to lungs, the survival is only 19 months, to the liver about 14 months, to bone 21 months, and lymph nodes, current survival advantages. Survival times are about 32 months. So clearly, metastatic prostate cancer survival is dismal, asking and requiring, therefore, need to identify newer treatment modalities to overcome this therapeutic resistance. So we talked about androgen deprivation therapy for prostate cancer, but the origins of androgen deprivation therapy are much older than prostate cancer itself. 1786, John Hunter, who was a veterinarian, identified bulls in which who were castrated, they had smaller prostates. 100 years later, in 1895, it was John White who put 111 patients who had severe benign prostatic hyperplasia. They were offered bilateral orchiectomy, and he showed that 87.2% improvement in the symptoms were improved. So these became kind of cornerstone studies. There was a lot of controversy whether bilateral orchiectomy was a useful thing or whether it really offered any treatment priorities to these patients more than what they suffered. However, there were no treatments at that time point. It was in 1941 when Charles Huggins performed castration as a means of controlling metastatic prostate cancer. He took 21 patients who had a metastatic disease, and he showed that 18 of the 21 had improvements in weight gain, resolution of anemia, and improvement in their pain. He received Nobel Prize for these unique findings in 1966. And this became kind of a driving force for current therapies targeting androgens and androgen signaling excess in prostate cancer. What is the modern problem with this work is that even Huggins' original studies did not show any cure to these patients. They were just improvements on resolving anemia and improving the pain of these patients. So clearly, this was not a curative therapy even then, and it is not a curative therapy today. Coming from the Department of Biochemistry, androgens are male hormones as known as testosterone and dihydroxytestosterone. These are components of the cholesterol, and 5-androstenol is converted to testosterone, which then gets converted to dihydrotestosterone in the prostate and promotes prostate growth. Androgens do not work in isolation. They have a receptor in the many cells which respond to androgens. Androgen receptor is present on chromosome Q11-12 fragment of the chromosome X chromosome. It has 8 exons, which span a long genome on this X chromosome. So exons 1 to 8 are assembled, and a functional receptor protein, which has a DNA binding domain. It has a transcription regulation domain, which helps.
ये एक कॉपी वापस करने की एग्जाम की कॉपी ना.
Can you please mute if you are not speaking?
Yeah, I think Dr. Smita, you have to unmute yourself. Dr. Smita Patnaik, you have to unmute yourself. You have to mute yourself, please.
So,
and I think all audience, all the people who are here online, they are supposed to, they are requested to make themselves mute. Thank you for your understanding.
Androgen receptor. Okay. Androgens work by working through the androgen receptor protein, which is a DNA binding protein and has the steroid binding pocket where androgens interact with it. Once androgens are bound, it dimerizes and binds this unique sequence in the DNA, scans through the nucleus, and turns on many genes and turns off many genes. So in schematic, testosterone gets converted to dihydrotestosterone in prostate epithelial cells, by alpha hydroxylase, and this dihydrotestosterone goes and binds androgen receptor, which prior to binding is bound to heat shock protein 90 and is localized to the cytosol of the cell and is not functional. Once activated by androgens, it dimerizes, it gets phosphorylation and other secondary modifications. It goes to nucleus and turns on genes associated with cell survival, cell growth, and one of the target genes is PSA, which is used as a marker for prostate progression, prostate growth, and prostate cancer progression. So from the days when people did castration to current day, there are new chemicals. DES was discovered in 1944 or introduced in 1944 as an anti-androgen. Cypron acetate, flutamide, nilutamide, and most potent anti-androgen bicalutamide, LHRH analogs, MDV or enzalutamide, apalutamide. These are all small molecules which are currently in use. At least bicalutamide, enzalutamide, and apalutamide or LHRH analogs are still in use in patients to overcome androgen excess and to promote well-being of these patients who have dysregulated androgen receptor signaling. Another class of compounds, 5-alpha reductase inhibitors, finasteride, dutasteride, baxdroside, and other analogs of these compounds which block conversion of testosterone to dihydrotestosterone are also being used in many cases. However, their use has been discontinued as it was observed many years earlier that in prostate cancer patients who received alpha reductase inhibitors, majority of them, although had a reduction in tumor volume, there was an aggressive disease in some of these patients. So Dr. Andrew Shelley discovered this GnRH analogs, which are hormones controlling the synthesis of androgens by pituitary, and he was awarded Nobel Prize and Lasker Prize for this. This is pictured me showing visiting Dr. Shelley in 2013 to learn more about his discoveries, who remains very active with about 3,500 publications to date. Now, therapeutic failure to prostate cancer happens by two ways. Either you have reactivation of androgen receptor activity despite these chemical treatments, and or you have the growth of tumor despite androgen receptor activation being blocked. So androgen receptor, as I told you, this has 8 exons. There are splice variants in many of these patients where some lose this ligand binding domain, especially RV7 is very common. Others lose other domains. So there's a protein which binds the DNA but has no domain to control using the androgen excess at this point, especially these splice variants which do not have ligand binding domain. Many of these patients do not respond to these therapies. So in general, to make long story short, androgen receptor itself can get mutated. Androgen receptor can change as a result of secondary modifications by cytokines, by signaling molecules, and by growth factors. It can undergo phosphorylation, simulation, or acetylation. Androgen receptor can have splice variants which will limit the use of anti-androgens for therapy. There can be overexpression of androgen receptor in many prostate cancer patients. You can have cofactors which can cause changes in the current regulatory mechanisms, and you can have prostate cancer cells making their own androgens so that they do not depend on testis-derived androgens, so the growth can continue. And all these changes result in therapeutic failure where cancer grows despite androgen receptor blockade externally, and there's a restoration of AR activity. Therapeutic failure in almost all patients. The second act of therapeutic failure is because of tumor progression, where there is a change in the cellular phenotype as a result of cellular plasticity. These cells transform from being luminal epithelial cells to newer variants, including epithelial mesenchyme transition and epithelial neuroendocrine transition. These cells, as a result of cellular plasticity, also acquire metastatic phenotypes, cell migration, invasion, and recolonization. And at this point, we really do not have many useful treatments for these patients who have undergone cellular plasticity. So current state of prostate cancer is in a state of flux where we have still some questions that have not been answered, and there are some answers that have not been questioned, and this dynamics is where the researchers continue to figure out small pieces of this puzzle to have better treatments for these patients. So this is another of our pictures from the lab at that time point, just to revive your memories. Our lab in terms of prostate cancer is looking at developing small molecules to overcome therapeutic resistance, targeting different segments of androgen receptor signaling. We're also looking to block translational reprogramming in prostate cancer by targeting elongation factor G1, 4G1, which is a scaffold protein in cap-dependent translation. Today, I will talk to you about some work on our work on prostate-derived epithelial transcription factor, or prostate-derived ETS transcription factor, and its spatiotemporal regulation of gene expression only. My disclosures, the current work is funded by NIH, NCI, R01, VA Merit Award, startup funds from the School of Medicine, and has been previously funded by other NIH VA funds, Carol Fei Standout Chair funds, Feisweiler Cancer Center, Hormone-Related Malignancies Program, Neurosciences Program at University of Colorado, and Dean's Commitment Funds. So we reviewed so far biology of prostate cancer, hormone therapy, its origins, little bit hand waving on tumor progression, and potential mechanism of therapeutic resistance. We have not talked about exploring these vulnerabilities, but we'll jump ship towards SPDF and PDF for now. So in general, in principle, we decided to look at why cancer cells, how normal cells turn into cancer cells. Any normal cell becomes cancer cell, and it becomes deregulated cell proliferation. It achieves features of deregulated cell proliferation. It loses tissue control. They invade normal modes of cell death. They survive in hypoxia. Then something else happens, and these indolent or locally aggressive tumors, they become lethal. They acquire this mortality, invasion, clonogenic activity, resistance to therapies. They lose many times metastasis, suppressor genes. They can survive extended periods of hypoxia. They undergo cellular plasticity. So what we know so far is that in terms of tumor development, there are viral infections, oncogene activation and inactivation of tumor suppressor genes, and DNA mutations which cause normal cells to change into cancer cells. Unfortunately, there are so many insults that our cells have to go through, and this process can only be slowed down at the most. We cannot block normal cells becoming these indolent deregulated cells. The second phase, though, the tumor progression, which is driven by tumor microenvironment, which has epigenetic regulation and genomic instability. Therefore, these conditions offer new avenues to control not cancer formation, but tumor progression, so that many of these patients who may develop early disease never go to die from the disease. Our goal, if in our lifetime, if we could restrict the growth from local disease to lethal disease, that's an achievable goal in our lifetime. So in some cases, there are inherent DNA changes which directly give rise to malignancies which are lethal, like childhood malignancies. So, but by and large, this progression from normal cell to indolent disease to lethal disease is common. That's why majority of these diseases, cancers, are detected later in the age, after 30s and 40s in majority of the solid tumors, they remain suppressed for some time till they progress to a more resistant phenotype and a more lethal phenotype. So our work has been to look at what role does this prostate-derived X transcription factor play in regulating this process from indolent disease to lethal disease. To rephrase again the biology of prostate cancer, it has been modified from Michael Shen's work in 2010 in Genes and Development. Normal gland I showed you has these luminal cells and the basal cells. As early stage disease, there is a PIN or prostatic intraepithelial neoplasia. Once these cells divide uncontrolled, they come out of this gland and they start spreading around. There's an adenocarcinoma, the latent version, the clinically detectable version, and finally the metastasis. This phase is initiation, we call progression, and tumor. These are when the treatments are received by these patients. So if we could diagnose disease much early, probably we could have a method to delay the progression of the disease. In terms of molecular processes, inflammation, oxidative DNA damage, telomere shortening, cellular senescence, reactivation of developmental signaling pathways are drivers of this tumor progression from normal to adenocarcinoma. Then therapeutic resistance, which is castration resistance in prostate, and EMT, epithelial mesenchymal transition or cellular plasticity, result in this tumor metastasis. In terms of genes that have been discovered over the years, NKX 3.1 downregulation, MYC overexpression, TMPRSS2 ERG fusions, PTEN inactivation, activation of MAP kinases, and EZH2 overexpression. So we discovered that during this tumor progression, one of these X transcription factors, PDF, is lost in progress, progressively decreased, and eventually lost in prostate cancer. So what is PDF? PDF is a DNA domain binding protein or a X transcription factor which binds to this unique sequence in the DNA. Full name for PDF is SAM pointed domain X transcription factor. It's a member of X, which is E of 26 transformation specific transcription factors. It binds to GGAT motif in the DNA. It is highly expressed in normal human prostate tissue. It is restricted to luminal cells of the prostate and luminal compartment. It is one of the super enhancer-driven transcription factors in prostate cells. X factors were discovered as the called E of 26 family because the founding member was discovered in a leukemia virus named E26. We have 12 families of X factors now. Many of you may be working in any of them, and PDF is a unique member to one of the classes of this X transcription factors. We reviewed the literature about 10 years ago and show that many of these proteins, X family members, only share the X binding domain, but they also have some overlap in other domains, which are protein-protein interaction domains and others which have controlling protein stability and protein turnover rates of these proteins. So there are negative domains, positive domains. In general, in addition to prostate, PDF is also present in our salivary glands, in lungs, and in the breast tissue. The other X transcription factors are widely distributed in multiple organs in the body. Unlike majority of the X transcription factors, which bind preferably to GGA sequence, PDF interacts with a sequence which is GGAT in the DNA. This is one of the memories from one of the meetings we went with Professor Nath, and he was giving his oration. I think it was in Lucknow, India, at that time point. So 11 years ago now, we discovered that PDF is lost in progressive prostate cancer, and in part it regulates two of the components of the metastatic cascade, including MMP9. So this was a paradigm shift in the prostate cancer world, because until that time, it was thought that PDF is associated with prostate cancer progression, because many of the patients who have more epithelial cells, they have more PDF at that early stage, but as the stage progressed, we found that at later stages, these cells lose actually this PDF, and there's a distribution. There are some cells which still contain low levels of PDF at higher levels. There are some of the tumors which have no PDF at all. Parallel to that, in cell lines, we found the early grade prostate cancer has enough of PDF, and later stages there's a decrease in PDF levels, and there's a loss in some of the prostate cancer cells as the disease progresses. So we generated this cell line, and we cloned PDF, overexpressed it in one of these cell lines, and did the biology of the prostate cancer. We found that reintroduction of PDF to PC3 cells prevented their invasive properties in 3D cultures, and they started forming again cell-cell interactome. The cells interacted with each other. They still grew, but they failed to invade the surrounding tissues. This is Maroon Bells in Colorado, where most of this work was conducted. There's a group of people who did this work in Colorado at that time point. And we also showed, using in vivo models, that PDF suppresses tumor metastasis, where we took these cells which had PDF expression in them, or the cells that did not have PDF, we put a fluorescent tag in them, and they were injected either in the tail vein or via intracardiac space, and we looked at the metastasis over a period of 12 weeks, and we found that PDF expression completely limited ability of these cells to have metastatic, not to have metastatic dissemination, but to prevent growth at the new sites. Again, some of the work, by then we moved to Shreveport. This is LSU Health Sciences Center in Shreveport, Louisiana, where we discovered that PDF, by that time TCGA data had become available, and we took all prostate cancer patients in the data set and looked at median survival in relationship to PDF expression. We observed that patients who have high levels or normal levels of PDF had a median survival of about 120 months, which is 10 years, whereas patients in the lower quadrant had a median survival of only 6 years. So there was a 6-year distinct survival advantage for median survival in patients who had high levels of PDF. Again, PDF levels were decreased in metastatic tissues as well as in the lethal prostate cancer. These are published, so I will just skim through some of this data. So we generated 2 cell lines with overexpression of PDF and looked at the biology of it in terms of what genes were regulated by PDF. This work was conducted initially in Denver by Sweetie Cole, then Vipin Gopinath in Shreveport, and Ray Wong, a graduate student at that time point. So we did unbiased gene expression studies looking at all the genes that were altered in these cells upon expression of PDF, and discovered that there was a gene set enrichment for metastasis-related genes in these prostate cancer cells in vector control, but all these genes invariably were suppressed when PDF was expressed. Similarly, we looked at another data set, migration data set, which had multiple genes in it. Again, expression of PDF limited all these gene expression. We evaluated the effects of PDF expression in multiple gene sets associated with either metastasis or tumor progression, and we observed that all these gene sets were suppressed when PDF was expressed. Clearly, in biology, we looked at cells have this epithelial marker E-cadherin, which comes on the surface and helps cell-cell contacts. And when PDF is expressed, there is more of E-cadherin on the cell surface. These cells fail to migrate. They fail to invade the tissue. And in terms of other genes, we observed one of the EMT regulators, TWIST1, was downregulated when PDF was expressed in all cell types, but other markers like vimentin and other proteins were sometimes suppressed and not all times, suggesting that this quasi-EMT state can be limited by PDF expression. Chin Dong was a researcher in the lab at the time point who did most of this Western work for us. And she showed that not only was PDF overexpression limiting twist expression, but when we knock down PDF in LIMCAP cells, which are in low-grade prostate cancer, cells obtained from the lymph node metastasis, that there was increased expression of twist, loss of ecadrin, increased vimentin expression. And interestingly, we observed that this luminal marker PSA was also decreased. And these studies led us to further look at the role of twist1. So when we knocked down twist1 in PC3 cells, we found that indeed ecadrin was overexpressed and PDF levels were restored too. So there's a reciprocal regulation of twist1 and PDF, and we were very excited to see this relationship because both of these are transcription factors. We thought this is an aha moment, probably we can see the direct regulation. However, there was no direct regulation. Nonetheless, when we combined expression of twist and PDF together, the patients with high twist and low PDF had a better survival of now about 11 years, and the patients who had high twist and low PDF only survived 62 months, which is about 5 years. So clearly, they do seem to play a part in the clinical disease manifestation itself. As I told you, we did not find any binding of PDF in ChIP-seq assays to the promoter or to the enhancer regions of the twist, again, suggesting that this regulation of PDF by twist by PDF is indirect at the best. We also did not find any twist binding sites on the PDF promoter, suggesting again that regulation is indirect. We observed nonetheless in ChIP-seq analysis that the PDF directly binds to keratin 18, which is a marker for luminal epithelial cells and is a distinct feature of luminal epithelial cells, suggesting that PDF might regulate, at least in part, this luminal differentiation by promoting keratin 18 expression. We did other experiments to confirm these ChIP-seq assays. To this study, concluding this part of the study, we show that PDF directly regulates cytokeratin 18, and cytokeratin 18 indirectly regulates twist. Twist and PDF indirectly regulate each other. PDF suppresses metastasis by limiting cellular plasticity at the best, and twist promotes this process by promoting EMT. Now, in terms of disease progression, then we show as the disease progresses in response to androgen deprivation therapies, there's a progressive loss of PDF, there's a progressive loss of cytokeratin 18, there's a gain of twist1, thus offering new avenues to probably limit prostate cancer progression or at least make androgen deprivation therapy more palatable and more extended relief to these patients using these current treatments. Now, in terms of biology of it, during the prostate, these basal cells, these are luminal cells. Basal cells have specific markers, cytokeratin 14, cytokeratin 5, and P65. Upon androgen stimulation, or when men achieve puberty, these genes are turned on, AR signaling, FOXA1, PDEF, and NKX 3.1, which result in these luminal cells. If you castrate these men, all these luminal cells will die, the basal cells will stay there. But if you add androgens again, these cells will start dividing. And by showing that PDF plays an important role in this luminal differentiation, especially regulating cytokeratin 18, it offers us an avenue to convert these basal cells back to the luminal cells. Again, this work is far from over. This is much of an early phase of the work. So then limiting, we decided if you knock down PDF in mouse models and then look at the phenotype in these cells. So this is work being done now in New Orleans in our current lab. So rationale then for our current work is that PDF, this prostate cancer, indolent prostate cancer, becomes lethal prostate cancer by achieving this cellular plasticity phenotype under the regulation, and this cellular plasticity can be regulated by PDEF. And if you overexpress PDF back in the lethal prostate cancer, which is metastatic, therapy resistant, and which has lost luminal cell identity, then the goal is to convert these cells back to not normal cells, but back to indolent cancer cells, which have luminal cell identity, and they can respond to our current therapies. That is the driving principle in the lab at this point. So is there a loss of cellular plasticity? Indeed, showing in the mouse models, which is a trap mouse model, which is a progressive model of prostate cancer, in early on at 12 weeks, they have a lot of PDF expression in these cells. There is ecadrin expression, and as the tumor progresses 30 weeks trap, there is neuroendocrine differentiation, and these cells lose PDF completely. So at least in mouse models, that is evidence that during tumor progression, there is a PDF is lost. So we can exploit these models to further study PDF. However, we also looked in the clinical data sets, TCGA, that loss of PDF is associated with epithelial mesenchyme transition. Also, the loss of PDF was interestingly associated with neuroendocrine phenotype, which is the most lethal and non-treatable part of the prostate cancer at this point. We looked at each of these dots is a patient. We looked at all patients from high levels of PDF to lowest levels of PDF. And we find that loss of PDF is associated with loss of luminal AR related signatures and the gain of neuroendocrine signatures. So all these are luminal AR signatures, and these are the neuroendocrine markers. So clearly, loss of PDF at least associates with this. Therefore, we hypothesize that if we re-express PDF in these neuroendocrine prostate cancer cells, can we make them more like these less aggressive disease? So how does PDF make so many changes? Our current unpublished work, we find that PDF alters enhancer landscape to promote a luminal differentiation. So our DNA, double-stranded DNA in the cells is tied to the bead-like structures, which are 8 histone moieties, and these then histones further compact the DNA called chromatin fiber. Now, these histones have long tails, which have lysine residues primarily, which play an important role in regulation of gene expression, or therefore serve as epigenetic regulators of gene expression. So there are specific markers on the genome that can tell you whether the gene can be expressed. For example, in heterochromatin, these marks of DNA methylation and histone methylation marks are specific that compact the chromatin so that these genes cannot be turned on. However, if these histones acquire new marks epigenetically, this gene can be now opened up. The chromatin opens up, we call this euchromatin and heterochromatin. So euchromatin is the only expressed chromatin in the cell. Heterochromatin, genes in heterochromatin do not get expressed. So heterochromatin is very compacted structures on electron microscope, whereas euchromatin, you can see the DNA many ways. So there are cis-regulatory elements which are non-coding DNA. They regulate transcription. There are also further divided into promoters, enhancers, silencers, and super enhancers for benefit of those who do not study DNA, who do not study gene regulation mechanisms. So there are select markers, again, beyond the scope of this. Enhancers have their own markers. They have closed enhancers, open enhancers. So this level of methylation, acetylation offers a second level of regulating expression of genes at will. These enhancers also many times loop back towards the promoter regions and promote expression, high expression of their target genes. So we observed doing the ChIP-seq analysis that PDF binding sites are flanked by H3K27 acetyl marks, H3K4 monomethyl, which are both active promoters and active enhancers. And this is unique to PDF, that it is not bound in any of the silenced genes. H3K27 trimethyl is a silenced enhancers. PDF binding was not shown any peak around that. However, it is only bound to active or poised enhancers and promoters. We also found expression of PDF in these cells using chip-seq analysis resulted in compacting the areas where PDF can bind. And again, there was increased luminal enhancer activity in these cells. Again, this work is incomplete, and we're still trying to figure out the mechanisms for that. Summarizing most of the work from our graduate student, Ray Wong, he said, their goal was to find transcription factors which will distinguish prostate cancer patients based on survival independent of other markers, which is a super enhancer related transcription factor in the prostate, is part of androgen receptor signaling, is differentially expressed during prostate differentiation, and the common genes from transcription factors distinguishing all these things. Only one gene he was able to find using his differential leading edge analysis, that is PDF. And he gave credit to me for doing that. Again, it's a younger me, and this is actually all work done by Ray Wong as a graduate student for analysis of the work. Now, these are, again, I was a graduate student long back. This brings the memories again from the PGI. From PGI to heading the department here, where there are faculty members with their own research areas, both in cancer, neurodegenerative disease, coagulation, and structural biology here. This is our current department here, the faculty members in the department. But work in progress, again, this is the gift I received from Dr. Nath when I left, and this is my one of the achievements being president of the Society of Basic Urological Research. If I have to trade, I will trade this any day for this gift again. So current work, we're also looking, we observed that PDF inhibits CCL2, which when PDF is lost, then more of immune cells can infiltrate. And our collaborative work with Maria Sanchez now is looking that does PDF promote liminal cells to become more aggressive by way of helping MDSC cells to invade the tissues and become resident in the tumor and thus have a worse outcome. So these are the institutions. The work was conducted primarily at University of Colorado, some work in Shreveport, and some work is being conducted here at New Orleans and the Cancer Center here in New Orleans. I can sit here early morning or late nights and talk about this, but the work was contributed by distinguished fellows, graduate students, and current members of the lab, which are listed here to name a few. There are also collaborators both at University of Colorado, Scott Lucia, the pathologist, David Crawford, the urologist, David Gross from Shreveport, the epigenetics person, Ricky DiBenedetti works on translation, Ranjan Pereira at Hopkins, Jyoti Hong, chair of urology at Duke, Amna Zubidi at Vancouver, and Zoran Kulik at Innsbruck. Without whose contributions, this work would not have seen today. So finally, we get answers only to the questions we ask. So, but they say wise people think alike, so do not ask any questions. So, but there's a fools also seldom differ, so you are free to ask as many questions as you want. And the take-home messages is that normal cells, these indolent cells and aggressive cells, this transition from indolent cells to lethal disease offers therapeutic vulnerability that can be exploited because these are targets, epigenetic targets and genomic instability can be exploited then not only in prostate cancer, but many other diseases. Any other tumors which are solid tumors and for which there is no cure. Indeed, we have moved on to look at epigenetic regulators in solid tumors, drivers of driver transcription factors, deregulation of protein synthesis, machinery, and anti-cancer activity of small molecules. We still focus on GU oncology, but have developed interest in pancreatic and breast cancer because of similarities in this cellular plasticity phenotype in these diseases. We had using PDF knockout mice, and to make a long story short again, knockout mice do show this dysfunctional or deregulated tumor cells in the prostate, and many of these cells many of these cells look like precancerous. Again, most of this work is incomplete. We also show that the PDF has a super enhancer related transcription factor using ChIP-seq analysis, and loss of PDF may promote prostate hyperplasia with basal-like cell phenotypes, where cells are now more like basal when PDF is lost. Again, this is one of the memorable pictures with Dr. Nath. We were in Cairns, Australia, and I salute both Dr. Nath and Mrs. Nath. Again, this is a picture taken in Cairns, and I thank you for your time.
Thank you, sir, for sharing. Thank you, sir, for sharing your vast expertise and experience. I'm certain that your talk has enlightened all the participants here today. I also take this opportunity to congratulate you and your entire team for this excellent work. As per the tradition of the Institute, a silver plaque memento and a certificate of appreciation is physically presented to the orator. But as we are all aware that this oration is being conducted to the virtual mode, so I now request our director, Professor Jagat Ram, and our Dean Academics, Professor G.D. Puri, to kindly present a memento to our orator, Professor Hari Kaul.
Thank you so much.
Most welcome. I now request our Dean Research, Professor Gurpreet Singh, to kindly present the Certificate of Appreciation to our orator, Professor Hari K. Kaul.
Thank you, Dr. Singh.
Thank you, sir. I now call upon our Dean Academics, Professor G.D. Puri, to kindly propose the vote of thanks. Sir, so you're not audible, sir?
Unmute करें Dr. Puri.
Doctor, Professor Puri, you're not audible, sir?
See Dr. Singh in audience.
Yeah, very much. Yeah.
Yeah, I didn't see you. Good to see you.
Sitting, yeah. Yes, I thought I will get opportunity to interact with you.
Yeah,
Yes.
last time we met at AUA.
Yeah, I know. Dr. Dahiya was available last week, 50 days ago.
Let's
Rajveer
wait
Dahiya,
for it.
yes.
We can talk. We can chat later. Let's get to it.
Yeah, to Dean.
वहाँ से होगा वो सर अनम्यूट करो बोल रहे
Dr. Puri sir, unmute करो.
Good evening. Am I audible now?
Yes, sir.
and visible, sir. Yes, sir. Please continue.
Professor Hari K. Kaul, orator for the evening. Dr. Arvind Nath, son of Professor Nath, late Professor Nath. Professor Jagat Ram, our worthy director. Professor Gurpreet Singh, Dean Research. Professor Sadhana Sharma, head of the Department Biochemistry. Professor S.K. Singh, head of the Urology Department, and other faculty colleagues from Department of Biochemistry and other departments, and all the other faculty and the audience on the webinar of this oration. It gives me immense pleasure to propose a vote of thanks on the occasion of the 9th Professor R. Nath Memorial Oration. First of all, I would like to express my sincere thanks to Dr. Hari K. Kaul, who is not only internationally recognized leading translational researcher in urology sciences, diseases. He happens to be the head of the Department of Biochemistry and Molecular Biology and Associate Director of Stanley Escott Cancer Center, School of Medicine at Louisiana State University Health Center, New Orleans, USA. I thank you, sir, for your accepting the invitation to deliver this oration and sparing time for the same. We are extremely elated by your talk on tumor progression and therapeutic resistance in prostatic cancer, and we all feel inspired by your great work related to the urological disease. You may remember your later part of the time you were here in late 80s at PGI, when I also used to be the assistant professor, young anesthesiologist and intensivist, and we used to come across a number of times. I hope you remember that.
I do.
I would like a deep sense of appreciation for Professor Nath's family for their constant and encouraging support to organize this oration. And here I must add that he happened to be the chairman of my doctoral committee when I joined PhD in late 80s at PGI Chandigarh. I sincerely thank Professor Jagatram, our esteemed director, to grace the occasion in spite of his busy schedule. And I take this opportunity to extend our thanks to all the esteemed guests, faculty, colleagues, residents, and research scholars who happen to be with us at this point of time for joining this event. Jai Hind.
Thank you, sir. Thank you, sir. I now seek the permission from our director, Professor Jagatram, to kindly conclude this 9th Professor R. Nath Memorial Oration.
Yeah, surely I think it was an outstanding oration. Now we permitted to close the oration.
Thank you. Thank you, everybody.
Thank you, sir.
Proud alumnus of PGI, yes. Dr. Khal is a proud alumnus of PGI, one of the
Glad to be back home today, although virtually. I will come one day again.
Okay, Khal. Right. Nice to see you. Thank you.
Thank you so much. I lastly end with these words. Stay safe and stay healthy during this COVID pandemic. Thank you so much, everybody.
Namaste, everybody.